Hi, everyone. Thank you for joining us for Black Maternal Health Week 2021. We are extremely excited to continue to celebrate the entire week. I am Kondeh Greaves. I am the Executive Director of Birth and Color RVA. Birth and Color RVA is a birth policy and advocacy nonprofit. We specialize in maternal health and reproductive justice and reproductive rights. We try to ensure that everyone has hold on one second. Sorry, I'm admitting people at the same time. We try to make sure that everyone is empowered, that they are able to have their voice, that they are able to advocate for themselves, and that they are able to just speak up when things don't go wrong. When things go wrong, and also that they are able to ask questions that they need to ask. We make sure that they know what's going on and what's happening within their birth, and that they are in control of their birth. We try to offer them evidence-based information to ensure that they have successful births, that they know their choices, and that they create birth plans. So I would like to welcome you all here today. I will be your moderator. So welcome. I will be reading the bios from each panelist that will be talking and answering the questions. So first we have Dr. Ann Brown. Dr. Ann Brown is an MD, has been practicing OB/GYN in Leesburg and Sterling, Virginia since 1994. Dr. Brown has been actively involved in leadership activities at Loudoun Hospital since her arrival, including serving as a chairwoman of the Department of OB from 2002 to 2005. Currently serving as the medical director of Women's Health Service Line in Inova Loudoun Hospital. She received a Golden Stethoscope Award for excellence in teaching in both 1992 and 1994. That is amazing. Dr. Brown has a strong sense of commitment to her patients and community and feels it's her job to approach the patient physically, emotionally, and spiritually. She considers it a privilege to be a Leesburg and Sterling women's health physician and to empower her patients to lead healthier lives, creating stronger women, stronger families, and stronger community. Welcome, Dr. Brown. Thank you for joining us. We have Dr. Gloria Ivey-Crowe. Dr. Crowe offers comprehensive care of the reproductive system in women across two specializations, OB and gynecology. The specialty of obstetrics covers women's health while in the prenatal and pregnant states, while gynecology deals with the care of general women's health in a non-pregnant state. Thank you so much for joining us, Dr. Crowe. Then we have Dr. Nicole Karjane. Did I say that right?
Yep, karjane. Mm-hmm.
Okay. Dr. Nicole Karjane is the Residency Program Director for Department of Obstetrics and Gynecology at VCU Medical School. She completed her undergraduate studies at your Sinus?
Ursinus, yep.
Okay, your Sinus College in 1995 and attended medical school at the University of Pennsylvania. She then went to complete both her internship and residency at Virginia Commonwealth University, where she has been practicing for the last 16 years. Her interest areas include pediatric and adolescents, gynecology, HPV, cervical dysplasia, as well as conception. Welcome, Dr. Nicole Karjane. We also have Ashley Venable, who is a certified nurse midwife. She is originally from Oklahoma, but currently resides in Lynchburg, Virginia, and is a certified nurse midwife. She attended Oral Roberts University in Tulsa for her Bachelor's of Science, and then went to pursue her Master's of Science in Nursing at Frontier Nursing University. She strives to provide evidence-based, family-focused care for the women of Central Virginia to help build and maintain a striving and thriving community. Welcome, Ashley. Now, I might mess this up, so please forgive me if I do. Feeta Carpart.
Feeta Capehart.
Feeta Capehart.
Feeta. He had a Feeta, feet like feet and a Feeta.
Did you have a different last name?
Nope.
No. Read your bio for me.
Sure. Do I have it up?
Miss Kenda, I could read it for you if you would like.
Yes, please do.
Okay. Feeta Caphart became a midwife to help women live informed, empowered, healthy lives. It is important to Feeta that those she touches feel seen, heard, and cared for. Born in Brooklyn, New York, and raised in Montgomery County, Maryland, she received her Bachelor of Science in Nursing from University of Miami in Florida in 2011. After working as a labor and delivery nurse for a few years, she attended Georgetown University's Nurse Midwifery and Women's Health Nurse Practitioner program in Washington, D.C., graduating with her Master's of Science in 2017. Feeta currently serves as a senior midwife at Brooklyn and Jazz Birth Centers in New York City. When she is not catching babies, Feeta enjoys reading, listening to podcasts, and spending time with her family and friends.
Thank you so much for that, Brianna. Why don't you introduce yourself?
Hello, everyone. My name is Brianna Harmon, and I'm an intern at Birth and Color RVA, and it was so great to be here, and I thank all of you for being here as well.
Thank you. So now on to the fun stuff. Let's talk about it. This is a safe space, so feel comfortable to discuss however you see fit. Nothing is off limits or off topic. Question number 1, and would you panelists like me to call on you, or will you just jump in?
So
We can jump in.
Okay. So Black women are 3 to 4 times more likely to experience a pregnancy-related death than white women, and are more likely to die from pregnancy or childbirth than women in any other racial group. What are your thoughts on this matter?
I'm happy to take that and kind of start off. So the first thing, I think it's heartbreaking and it's embarrassing. We're supposed to live in the best country in the world. And as many people say, like, you know, the way we treat our women is kind of a testament to how the society is going to be. And the fact that we don't do better with pregnant women in general, like we have the highest maternal mortality overall of all developed countries. And given our resources, given what we have, it's an embarrassment. And I didn't realize it was that bad. Like I went to medical school so I could help people, you know, so I could fix all the problems. So I would learn, I don't know, the other physicians, so you would learn everything. Didn't you think you were going to learn everything in medical school? And then the more I learned, the more I realized we don't know everything. We're still learning. We need to keep learning and we need to keep getting better. And, but I think that unless we start doing better with our women, particularly our women of color, there's not as much hope for us. Like we must do better. And I think it's a multifactorial problem. And we as a society just need to pull together and take the best and the brightest and reduce these disparities because, as I said, it's unacceptable.
I totally agree with you. This is Kondeh Greaves. I'm an OB in Northern Virginia as well. And it's really sad. And, you know, I was looking at Virginia Department of Health's statistics just in preparing for this. And between 1999 to 2000, the maternal mortality rate for Blacks is 79 per 100,000. Compared to their white counterpart, where it's 34 per 100,000. I mean, if that doesn't jump out at you, I don't know what does, you know? And I'm sure all of us panelists on here are very caring, compassionate physicians, midwives, and providers, mid-level providers, and we're doing our best every day for our patients. But I think the whole purpose of this week is to highlight this disparity and bring attention to it. And hopefully we can all do better in the medical community to address our women of color and their issues and listen to them, be empathetic, because when they say they're hurting or they have a problem, a great example I like to give is of Serena Williams, the tennis professional. She has all this money. She tells them she's having problems breathing. She knows her body. She had a history of a pulmonary embolism with her pregnancy, postpartum. She was telling them she was having issues breathing. They didn't believe her. And she asked for a CT and she knew exactly what she needed. They didn't want to, but they finally did want a VQ scan, a CT, and then they found out she did have a PE. But, you know, just tells you it cuts across the socioeconomic status. No matter how much money you make, whatever, there's still this disparity. But so, yeah, it's tragic.
Thank you so much for saying that, Dr. Graves, because that is the biggest stigma, is that it doesn't happen to the wealthy, that it is only for the underserved community, and that's what everyone targets. So even with Birth in Color, they always like, okay, well, let's target the underserved. And I'm like, but it happens all across. So we could target them and we can help, but what are we doing for the middle class and the wealthy? Because it is a real issue. And the CDC stated that 68% of the deaths were preventable. So that's when you have to go back to, are you listening to what they're saying? Because I can tell you the numerous times that clients have told me that they weren't listened to in the doctor's office. I've seen them not be listened to. And so when you speak up, they're like, oh, they're aggressive. And I'm like, no, we're not aggressive. We're trying to tell you that you aren't listening. So you're making us have to be louder and you're still not listening. So how can we actually fix these issues? And I did not read Dr. Graves' bio, and I want to read that now to make sure that everyone knows who she is. Dr. Graves was born in Liberia, sorry. It's misspelled on my paper, where she spent her formative years, as well as Zimbabwe, which greatly influenced her life and global view. Dr. Graves holds a dual Bachelor of Science degree in pre-medicine and medical terminology from St. Augustine's College in Raleigh, North Carolina. She is a graduate of Meharry Medical School in Nashville, Tennessee. She completed her internship in obstetrics and gynecology at Emory University and residency at Wayne State University. Dr. Graves is a member of several professional organizations, to include American Medical Association, and is a fellow of ACOG. Dr. Graves is passionate about social causes, both locally and internationally. She has done medical missions. Dr. Graves loves spending quality time with her family, traveling CrossFit training, movies, music, volunteering for social causes. She currently works as an obstetric and gynecologist at Mid-Atlantic Medical Group in Northern Virginia. Thank you so much for joining us.
Thank you for having me.
I have a little story to tell you. When I was born 57 and a half years ago in Cleveland, Ohio, my mom was a patient of a private practice, but when she arrived at the Catholic hospital, all the private rooms were taken, so she was put in one of these large wards where the majority of patients, used to labor in the old days. And then, you stayed in the hospital for like a week after you had a baby. And she always tells this story that really made an impression on her, that there was a Black woman in the bed next to hers, and she had twins. And one day her doctor, who was a Black man, came in to check on her, and he lifted her sheet, and she was sitting in a pool of blood. And he had a canary about how the nurses were not looking after his patient adequately, because otherwise they would have seen that she was hemorrhaging out. And I guess in the end, everything turned out okay from what she understood, but that really left an impression on her. And I don't know that there's been a whole lot of improvement in 57 years, despite, the best efforts. I was doing some research as well this weekend. So as I so I didn't look like an idiot on this panel. And, there have been efforts to improve things for a long time. There's a group out of, I can't remember exactly, but I think it might be Emory. There was a Dr. Avery from Atlanta who started an organization in '87 called the Black Women. It's now called the Black Women's Health Imperative, that has a lot of goals that are very similar to your organizations. And in 2018, there was legislation to that effect for women's health, Preventing Maternal Deaths Act. And then, here we are in December of this past year with HHS coming out with a big effort, Healthy Women, Healthy Pregnancies, Healthy Future Action Plan. And so, there's a lot of great ideas out there. It's a matter of actually putting them into practice and, talking the talk and walking the walk also, And so I hope that we come up with some concrete action plans that we can all utilize today.
Well, I just wanted to comment on the prevention thing. I think for me, and I think all of us as panelists, it tugs at not only the numbers that we heard, but just the idea that so much of this is preventable. We're working every day, going and trying to do our best, but it's the people that we don't reach that is the group that if you could get them in, you could be on top of them. They could get prenatal care. We could be able to identify those things, those chronic conditions that they may have that leads them to be at increased risk. But the thing that kind of always has run in the back of my mind, and even with this information too, is we've got to figure out a way to do it a little bit different, because as much as we want them to come to us, we've got to reach out and go to them and try to look at a more different, not necessarily the traditional way that everybody comes in the office, but that's where we've been looking at, the things with the mobile vans, the things that, how do we reach out and get this community of women who are there? They just can't get necessarily to us. And especially if we're talking about women who are underserved, some women who just routinely for Medicaid need to make arrangements for transportation. I just keep thinking we need to think outside the box, and we're in the office, but we got to get some feet on the ground too, and try to figure out how can we take that healthcare to those women on another base, on a regular basis too, especially for the things that if we could put our hands on them, we could prevent, if we could be able to put in place some standard sort of things for them to be able to do, resources and different things. So that's the part when I kept thinking about the prevention part, is that this is preventable. What if we could get our hands on them, we're going to take care of them, but we haven't been able to get our hands on them.
Right. And that's where community organizations, activists, doulas, home visiting, and all of them come into play at, is just everyone has to work together. And so instead of everybody being separated, or this is what I do and this is what you should do and you need to stay in this lane and not networking to each other, if we all have the same client, we should all be discussing what the client's needs are and how can we effectively help this client. I had a discussion today earlier about creating the mobile vans, especially for the royal communities. I know in Virginia now, doulas will be reimbursed for Medicaid. And so that's a way that we can also help. We actually put it in the action plan that, if the doulas can help out or network when the client doesn't have accessible transportation, that we could definitely share resources so that we can make sure that they're meeting their prenatal visits, because that's the goal of community organizations. They have built that trust with all of the clients, so they trust them. So they're going to know the needs versus the providers, because we're with them longer. So we're actually navigating, we're talking, and all of those type of things. And I know midwives, they have hour-long visits because they're able to. And so that's where that can come in also, where you're discussing and you know what the needs are and you're connecting them to different resources. There's no reason why everybody doesn't have a connection to someone that's in the area. So you should be able to have a connection with the LCSW or a social worker or the OB to, or the OB's office to say, hey, this client is not going to be able to make it because she's having this transportation. Is there any resources that we could put together for her? Like creating an ultimate resource guide to where we know how to network with the client, especially when we all have the same client. We should all be like, okay, well, we know that this client is doing this. And I know what I like to do is, if I know a client needs something, I'm like texting everybody that I know and like, hey, here's the email. I don't give specifics about the client's name until I know that you can help. I was like, this is a situation. Can you help? They say, oh, yeah, we can help. Send them over. And I'll have the client contact them so they can set up and share the resource. You, everybody spoke. Do you want to speak to that question, Ashley? Or are you good?
Yeah, I agree with what you said. I think that one of the biggest things that we can do is putting into place some really great community groups and activists that can help us get access and figure out ways to increase our access to really great care. Because as we know, like I think that Gloria said, it's the ones we can't get to, that if we could get to these women that we could help, that we know or have had a really bad experience in the past with the medical community and maybe are not reaching out in fear of that happening again, by having a community group that they're comfortable with and have gotten education and feel supported from, with us making a connection with them, then we can say, hey, we're helping this community group. We work in, really close with them. Let's figure out a way to make access to care better for you, but then also find you a provider that you feel is going to listen to you, that's going to take care of you, and that's going to be actually spend time and not push off of those needs that you feel are important. I may not feel like they're a big deal, but if they're important to my patient, then that's something we're going to focus on. And finding those women and being like, let's start off from the beginning, even across all demographics, socioeconomic, we hardly ever have the opportunity to get in front of preconception care for women. But if we could start being able to see more of those patients for those preconception visits, or helping them with their GYN care, and then saying, hey, we can transition into your birth once you're ready, if you're ready to have children, if that's something that you desire, let's talk about how we get you to a better healthy path initially, so we can help you control those chronic conditions, make sure we have those referrals set up if we need them, finding other people to help manage that care. But in the end, getting us to those patients is the biggest part. And I think community groups is a great bridge for that, for sure.
Thank you.
I would also like to add that, kind of stepping back to what Dr. Greaves said earlier, it is very important for the community outreach in the network, but it's also important for us to address the systemic and interpersonal racism that impacts the Black and brown bodies that are coming into, healthcare in this way. There are a number of women that we can name who have become famous, who were actively advocating for themselves and still died. And they were, getting all of the care that they were supposed to be receiving and still died. So what is happening there if we're saying that it is preventable, that what they died of was preventable? If it's not that they didn't get the care and advocate for themselves, then there's something else there. And we, would be, it would be remiss of us to not mention that racism is a very big undergirding of why Black and brown bodies are having this happen to them in this system. And so to me, that's the most enraging thing about hearing that statistic every time I hear it. And it's also sad, and it's fearful. Like, I can't imagine what it must be for my pregnant patients and people who are wanting to get pregnant to hear those statistics and say, well, that happened to me. Like, pregnancy is supposed to be one of the most joyful parts of your life, to be bringing new life into this world. And you're afraid that you could lose your life, your baby could lose their life, or both of you could be maimed or have some long lasting health effects because you weren't listened to. And there could have been implicit or explicit bias at play in your care.
Thank you for that, because I was going to definitely say that before the end of the night.
Mm-hmm.
I definitely agree with you on that. I know I teach racial bias training to healthcare providers, and that's one of the biggest concerns is that uh, because I teach racial bias training and I get to do like the pre-assessments and the tests and stuff like that, seeing the pre-test and that they're still thinking that all Black people have underlying conditions, it's so mind-boggling to me. I'm just like, we're in 2021 and we still think this way. And I have to always go back and say it, and then like I always have like these fun games within it, and they actually get to see their own bias. They're like, wait a minute, like this was a trick. And I'm like, yeah, it was, because I wanted you to actually say that you have a bias, not like at the front and like, oh, we need to do this and we're trying. And but in reality, you might be trying, but you're not trying hard enough. And then sometimes, it's the whole question of, well, I'm not racist. And then like, I don't know if you ever had that friend growing up where they're like, well, I'm not racist, I deal with you. You deal with me, but you're racist for making that statement. Because you wouldn't necessarily need to make that statement. And so that's the way it goes. And certain things that happen, or not the culture difference. It's like understanding the culture difference. Like when Kim K came out with the cornrows, it was such a fad. But when we wear it to work, it was such like people were like, y'all, we really have to have a bill about Black people's hair. Yes, we do, because we're looked at differently when we wear the cornrows or the weave or any type of thing. Right, Dr. Greaves. We're looked at differently. And so when we have these conversations, they're like, well, what are they talking about? How your fan base, because Kim K did it and it's so cute, but when we do it, it's problematic. And the reality of it is, culturally, we kind of start a lot of things, but it's always taken around from us and created as in a different way that glorifies other counterparts. And so when are we going to talk about that? Those are issues. And that's why all of the systems need to be recreated for us as well. Because people don't look at it that way. They're just like, oh, well, that's not a big deal. Well, it's a big deal to us because when I did it, you said, oh, that's crazy. Or did you see, why did she wear her hair like that to work? People are going to look at us all crazy or something of that nature. Like, that's why we have to keep having these conversations, because are we going to keep having the conversations, or are we going to actually have resolutions? Because people can say that they want to do stuff all day long and they want the system to be better, but without the resolutions and actually creating the things that need to be done, we'll never get anywhere. Which brings us to my next question. How do you as health professionals care differently for women of color, specifically Black women, when they're your patients?
When I saw that question, the first thing I thought of is we're providing a service and a care that we're giving. It doesn't have a color. We are not saying, well, this is a Black woman, this is a white woman, this is an Indian woman, this is a woman. I would like to think that we're all providing a standard of care that it has no color. Now, what I then looked at the question and kind of thought of it on a different level was that, what do I have to do a little differently if I have somebody of color? So is that the patient that I have to maybe carve out more resources for her? Because as I may do my same way I deliver care to no matter what race she is, I may find that she has some other things in her social life that may prevent her being able to do some of the things as readily as maybe one of somebody of another race. So I don't provide care differently. I find that I may have to do some additional things because I have to maybe put some things in place for that patient that I may not necessarily have to do for this other person. This person may have to say, you know what, I know I can't do this because I got childcare issues. So yeah, you want me to come in for this visit? I can't come for that time of the day. I can only come when somebody's available to take care of my kids. Or, I know I need to come back and I know I need to get into that sonogram, and that may be the location, but they don't take my insurance. So then you get a call back. So in that context, you're giving your the same standard of care, but you may have to delve out and look and do different things and make amendments or adjustments because they don't have different things in place that somebody else may have.
Yeah, I think that there are differences that we need to acknowledge so that we can provide better care. We know, for instance, that Black women have a lot more fibroid tumors. They have them bigger and earlier in life, and they can have implications for their reproductive health. And, you know, looking for those diagnoses, knowing that they're statistically more common, to me isn't a bad thing. It's a good thing. If I have a patient that, has a real strong family history of hypertension, I know that she's more likely to manifest those types of problems, especially in my patient population here in Northern Virginia. We have a lot of older moms that have delayed childbearing. And, I'm going to need to stay more on top of her. I have to be more cognizant of those kind of issues because I've seen a lot more of those cases kind of spin out of control more quickly. So I think, you can be colorblind all you want, but I think sometimes they deserve special care. You know what I mean? If they have, a history or at risk for certain problems. We know that growth retardation is much more common in Black moms, particularly hypertensive or older Black moms, but even just baseline, it has a higher incidence. And I was reading some really interesting stuff, some theories about how, what is it called, weathering or something? Have you heard of that? That it's the chronic stress, partly due to living in a racist society, that they feel releases more stress hormones. And in pregnant women, that has a higher chance of leading to smaller babies, which we know are at higher risk for premature birth and death, stillbirth. And, if you have a recent immigrant from Africa, they don't necessarily have the same rates of growth retardation because they haven't been chronically exposed to, and this is all theory, it's hard to prove this type of thing, but I thought it was a fascinating thing that, makes our Black and brown patients deserve special care, not just run-of-the-mill everyday care, but special attention.
I agree. There are cultural differences and there are culturally specific problems for each group of women. Okay. And in the Black community, for me, representation matters. So as a woman of color myself, stepping into that room is important, that not only that I bring my medical expertise, but I'm relatable as a woman of color. So for that's an entrance already, making them more comfortable and more relaxed for us to have that conversation. So it relaxes them. And then I use that opportunity to educate, because I find a lot of times knowledge is power. A lot of our people, women of color in our communities, Black and brown communities, do not have all of the information that their white counterparts may have to affect their health, to make informed decisions. So then you have the paternalistic and the implicit biases where people think, oh, she's had 5 babies, so yeah, therefore I'm going to push this IUD on her or push her to get sterilized. And then you have these historical problems in the past where women were sterilized in the South unbeknownst to themselves, that they had been sterilized. So there are long-standing racial injustices and bias and implicit biases in the medical community that we have to acknowledge. So for me, diversity, representation in my case really is helpful, education, and then being empathetic, really, really listening to the patient. I went to Meharry as a medical school. It's a historically Black a medical college, and it was one of the few, Howard and Meharry, where they train the few medical doctors in the country, women and people of color. And they told us what really made a Meharry doctor distinguished us was that we always had very good bedside manners and we were taught to listen to our patients. Because 90% of the time, the patient through your history will tell you what's wrong with them. Because a lot of times we are given 10 or 15 minutes, we're looking at the clock, we're trying to get out of the room, but sit for a minute. Listen to what the woman is telling you. Pause. If nothing else, this pandemic has taught me to sit and pause for a second and reflect about my life and what's important in my life. But it should be telling us the same medically, to really think, how can we change this system? So I'm really glad that ACOG is trying to move forward and trying to change, have a cultural shift and promoting that we should start thinking about changing these implicit biases and dismantling the medical institutionalized racism. So for me, empathy, listening to my patients, educate them. I can't do that enough. And just the fact that I am also a woman of color, I think that diversity brings something to the table.
I love what you said. I think that was awesome. And I can to add to that, I feel like especially over the past year with just all of the stuff that has been going on. I mean, I feel like our world, our country is insane. And so I've been taking just extra time to try to understand all of my patients, but particularly my patients of color, and how, whether it's the horror of the George Floyd murder and other absolutely like horrific instances of police brutality, like how that's affecting them and affecting their families. Or, with COVID, how is that, so whether it's a social isolation or the clear disparities in infection and death, and like how's that affecting them or their families? And then finally, as was said before, really kind of striving to understand the patient and be their partner. That's one of the things, that's why I went into medicine. My mom was a nurse, and I was just always so proud of her, and she just really cared about connecting to patients. And that's, what I've really tried to do my whole career. But be their partner in care. So not just someone, I know a lot of physicians are like, oh, I'm the doctor, you need this, this, and this. And that doesn't work. It might work for some, or they might think it works, but unless you really partner with your patient, and as you said, Dr. Greaves, like listen, like really listen to what is wrong. And because if you don't have that relationship where you are partners, then you're not going to be an effective healthcare provider, because they're not going to buy in. And, I heard earlier, like trust is so important in all of this. And both I, as a provider, have to trust my patient that she's going to tell me the information that I need to know. And I need her to trust me that I care so much about her, and I want her to be healthy. I want a healthy baby, a healthy mom. I want everything to be perfect, right? And I want to follow the birth plan if I can. But if I'm saying, oh gosh, I'm really worried, your baby's in distress, I know you don't want a C-section, but I really don't, I don't think we can wait any longer for a vaginal birth. And I need her to trust me that I am doing that, not because of the time, because that's one thing I love about being at VCU is, we staff labor and delivery 24/7. So no one ever gets that 5 o'clock C-section. Which sadly, I've had a lot of patients, particularly patients of color, that had that exact thing happen with their first pregnancies. And then they come see me because they want to have a VBAC. And when I look at stuff, I'm like, oh God, like it breaks my heart. But I really think that partnership and the trust and building that relationship is so important. And I think I just had a patient today, I was on labor and delivery, a patient and her mother that felt like their provider just was so negative to them and just kept saying, oh, well, you're at risk for this and you're going to get this and you might get this and all these bad things. And they just wanted to be, I feel like my job is to kind of help you down the healthy path and provide the guardrail. So if you veer off, and like I'm going to catch the problem and help bring you back to healthy. But I'm not there to say, oh, but this might happen to you. It's listen and really work on the health and the partnership, and just keep people safe and help them feel empowered to talk. And if they're worried, please speak up. Like, what are you worried about? Why are you afraid? Are you sad? Are you scared? What are you worried about? And help me, make eye contact and really listen so that we can all get to the same goal, which is what we're all here for, is keeping women healthy, reducing disparities, and kind of especially making medicine. Like, I don't want medicine to be a disappointment. some of the questions, like it's disappointing, and we can do better. We absolutely must do better.
Yeah, I would say for me, at first, when I saw this question, I also was like, but I treat everybody the same. But I thought about it, and I know why the question was asked, because yes, Black women, Black people often feel unheard, feel unlistened to, brushed aside when they voice their concerns in the medical industrial complex, and they don't feel like they're being listened to. And I feel that me knowing that as a Black woman, that helps me bring in myself, when I come to meet with my clients, my patients, and knowing that history, even having that experience of someone not listening to me, it helps to inform me and helps me to know that I need to empower my patients, to help them for me to be an advocate for them, but also for them to be an advocate for themselves, to feel empowered to be an advocate for themselves, and to take my time as I'm meeting with them, take my time to explain what I'm doing, explain why I'm doing it, the, avenues for their care, and I also strive to be better trauma informed, because we as providers, I think that is one thing that I am learning more and more still, that like we, even in the ways that we speak about healthcare, about the way that we provide healthcare, and the way that we actually can behave with patients, people can have some severe, hangups about even just being in an office setting with a provider. And so being well versed in that, so that they feel at ease and know that I am listening to them and that I'm going to hear them and do all in my power to address the concerns that they have, or just answer the questions that they have. So yeah.
Thank y'all so much for answering that question. I'm gonna be honest, my interns know me so well that they created these questions. And so when I read them, I looked at that one and I was like, okay, I done taught y'all well. Because that's something I would have put on there. So originally, why we think like this is because you have to treat them differently. Even though you want to say like, okay, I treat all my clients the same. When you have a woman of color, especially particularly a Black woman, you're going to have to gain her trust. And so medical providers don't necessarily, I think, because when they go to medical school, and this is just my opinion, y'all, that they're so trained on science and medicine, and that they lose their regular values, like communication and how to open up a conversation. I've had doctors just tell me like, Kenda, I don't know how to say that. Like, how do I like take it out of context and say it differently? I said, your people skills come in to play. Like, if you don't come in the room like you're a person instead of a doctor, they're not going to trust you. And that's why community organizations are so trusted, because we come as ourselves and we're going to tell them how we feel, whether they like it or not. But we're going to come in as ourselves and not just think about science all the time. And asking them a quick question about how are you today, and like sincerely meaning it, goes a long way when you have clients coming to you for assistance. Because if you're not genuinely talking to them, they're not going to feel like you genuinely care about them. And so until we actually have that mindset, across the board, they're never going to always trust every medical provider that comes their way. So that's like the infant mortality rate. In Virginia is 9 times higher right now. And so they did a study on the reductions. And so when they had a person that looked like them, they felt a lot better. And it wasn't because that person actually looks like them. It was because that person knows what it's like to be them. They know what they're going through. They automatically are asking those questions. They're being genuine and they're starting conversations. every time you meet with a client, you should start a genuine conversation just to say, how are you doing? Stopping for a quick moment just to say, and how are you doing? How are you doing today? And if you can remember something that they've told you from the past and bring it back up, you have won that client over to where they're going to tell you whether they don't have food in their house, whether they had a trouble getting there, whether your nursing assistant was nice to them. All of that is going to come out. But you have to be able to take a pause and say, hey, all right, in between clients, like I know that we realize that it's a rush situation when you have all these clients to see, but just taking that breather and saying, okay, I'm going into the room as a person and I need to figure out what's actually happening, and remembering that they're a person just like you're a person, and how you would want to be treated and how you would want to start the conversation off, especially when you're talking about the health of a person. And it's really that simple. And we've seen like all the changes when people actually just introduce those concepts. It really does mean a lot. I don't want to be treated like, oh, I'm just another patient and I'm trying to get home and it's 4:30 and I actually want to walk out these doors at 5 o'clock and we got to clean up. Like, that's not what the clients want to hear about or see.
One of the beauties of being an old doctor is that you do have relationships for decades, and you can have a better memory, after having seen them year on year on year, a lot of their family members. And Brianna can tell you, she shadowed me for a little while in my office, that I have a sticky note in my medical record, and I put stuff like, and not just for Black women, for everybody, if they took a trip somewhere, or if their mother was in the, nursing home, or if they just lost their husband or whatever, just some little non-medical thing. And man, do you get mileage out of that. You really get mileage out of it. And I'm, they're not stupid. They know you didn't memorize all that stuff, that you wrote it in the chart and you took the time to read the chart before you opened the door. And then the other thing that I tell my students is that, if you sit down, you give the impression, even if you spent the same exact amount of time with the patient than you would have if you stayed on your feet, you give that impression of having been there longer and cared more. So those little things, like you said, can make a big difference in perception. And, perception's 9/10 of the law, right? And so I try to impart those pearls to all my students all the time, and hopefully other providers, like I'm sure Nicole has all her residents that she gives helpful hints to as well.
Yeah, and just the fact that, you ask those things and then remember them, because, I have the same things, and because I care about my patients, I want to know, like, God, your husband passed away, I'm so sorry. And then the next year, hey, how are you doing? I know it must have been a rough year, the first Christmas without your husband. Like, those little things matter so much. And then also, I love what you said before, Fiona, about I'm blanking right now. But with the trust of the patient, but then also, what was that last thing that you talked? Oh, this is making people comfortable, especially with OBGYN and women's health. We're talking about the most sensitive things. I mean, who talks about sex to like random strangers? Who talks about their vagina itching? You know what I mean? Like, if you cannot make your patients feel comfortable, you're not effective. And it's so funny. I just felt like I had this light bulb moment just this evening when you said that about, like just really listening to people and making people feel comfortable. And like, you can't go in as the doctor with the white coat and the boss, like the dictator that's just like, I know everything and this is what you need. Because one, we don't know everything, as I said earlier, and two, we don't really know what you need unless we really listen and unless you feel approachable. And I remember, back when I was a resident, part of why I went into do peds and adolescent is that one of my mentors, he said, God, Nicole, you have to stay in academics. You have to take care of these adolescents. And I didn't understand why. Well, I had just gone into a room of an adolescent patient, and I sat on her bed and I was asking her about, like, just asking her about school and all these things. And then finally got to the bottom of what her problem was. And he's like, I can't do that. You can do that. And I didn't even, like, I wasn't even trying to do anything special. I was just really trying to understand my patient. And I think I learned it from my mom, who's like the nicest, sweetest, most compassionate. She was an RN, and then she went to get her nurse practitioner. And I think I just learned, like, I want to take care, like, really take care of people. I don't want to be the one that knows everything and tells people what to do. I want to be the one that just understands and cares for people. And I really, as you said, like, Dr. Brown tried to teach my residents that. You know what I mean? Like, that's how you're going to be effective. You can be the smartest person in the world and you can know everything. And if you can't communicate with people and if you can't get to know them, you are not going to be a good doctor. And trust me, I have seen that in medical school a lot. And they don't even understand and don't even want the feedback. And I think as providers, the best thing we can do is continuously learn. You know, like, I'm learning so much from just everything that's happening in the world and how we can do better. And I'm glad that there are community activists, like, bringing all this stuff to our attention and demanding better, because we, the women of Virginia, the women of our country, deserve better. And I think training, I feel hopeful that in an academic setting, in a training situation, that we can, one, try to recruit students who care about people, like, don't just care about being the doctor, but care about people and making a difference, and also can relate to people. Like, I can teach you stuff, you know, I can get you to pass the test. There's some things that, like empathy and people skills, that you can try to teach, but sometimes it's just there or it's not. And we just need to take the people that are really passionate and teach them what they need to do to learn kind of academically to be successful.
I think that's one of the biggest things too when we talk. I'm sorry, my dogs are freaking out. That we have the opportunity in our community to also help with 2 rotations with the first year family medicine residents. And I think the biggest thing that we try to teach them is that we want them to step away from the computer, paper, whatever you're looking at. I want you to focus on the person, and telling them, and I think Dr. Brown, you said the exact same thing. Like, one of the things that biggest thing I took away from midwifery school is that we never stand when we talk, we always sit, because even though it's just a change of perspective, you are literally on the same level as the patient. And I never want to present myself as my body language showing that I feel like I am more knowledgeable than you, that I have the control of this room. No, what I'm trying to do is come down to your level and let's meet where you feel comfortable so that we can have effective collaborative communication. And one of the other biggest things is, I don't know how many times that we see women in our office or up on the unit that felt like they were never given the part or the tools to be part of their care, that they were always told exactly what they had to do. You know, this is what we're going to do. This is why we need to do it. No, let me tell you what I'm seeing, why I feel like this is what's happening. And then let's talk about what your options are to care for this problem or to care for, and then say, well, what are your concerns? And like someone else had mentioned earlier, if you take the time to pause and listen, 99% of the time, they're going to tell you what's going on. It's not necessarily, I remember in learning how to write a SOAP note as a midwife, one of the things that they said, always ask your patient, what do they think is going on? What do they think this issue was? Well, you know, it sounds like I think it could be this, but what do you think it is? You know, have you done some research on it? Have you had this issue before? And a lot of times people saying, oh, well, I think my last provider did this for me, but I'm not sure if they did. And I would say, well, did they tell you what they were doing? No, they just did it. Like, that's not okay. The care needs to be informed and it needs to be patient-centered and patient-focused and women empowered, because like Nicole said, like, how many times are you just talking to a random stranger about these sensitive topics? Like, the fact that they are coming and having enough bravery to step into your office, you make that space comfortable so that they can share those most sensitive topics with you. And if you are able to meet them at a comfortable level and build that trust up, they're like Ken said, they're more willing to tell you, hey, I don't have enough money to feed my kids. I had a really hard time getting here. I only have 15 minutes today before my ride needs to go back. And then, I think one of the biggest things that once you've established that relationship that we've seen through the pandemic is how much, if we have the access to internet, how much telehealth can be like, hey, let me call you later today. Here's more access and more resources that I can make available to you that we can do on your time. But, establishing that initial comfort with a patient is huge. And I feel like a lot of women don't and have not had that in the past. And I think that that's truly a shame and that we have to make it better.
Yeah, I definitely agree with that. Next question. Do you believe that the institutions set up to train our health professionals do a good job in educating people on how to care for women of color?
I can start with that one as someone who's works at a medical school. And I think it's an awesome question and something I've really been asking myself over the past several years. And if you had asked me this question 5 years ago, I would have said absolutely yes, we're great at it. And I think we tried. I think that we thought we were good at it. So one of my mentors used to say, the eye doesn't see what the mind doesn't know, which is really profound. It's true in so many, many ways. But I think now that the realities of the healthcare disparities, especially amongst women of color, are just in plain sight, it's really clear that we haven't been doing a good job about it. I think we thought we were, and we haven't yet. That's it. But having said that, I do think that now more than ever, medical schools and other institutions that train healthcare providers are really working harder than ever to be better at this, whether it's training in culturally competent care or really what is, I think, more important, the cultural sensitivity, or recognizing and combating unconscious bias, right? That unconscious bias training that you do is so important. And there are still, I will tell you, there are still providers out there that are that's BS. I don't buy it. And it makes my blood boil because it's true. And I think especially if you think that, everybody has unconscious bias. You might look at me and I might look like a girl you hated, and you might be like, oh, I don't like her. And then you might get to know me and say, okay, I'm checking that unconscious bias because she's actually really nice, or something else. Or maybe there's someone that you think you connect with, and then you realize, it's not exactly what you thought. But unconscious bias is really there. And I think the medical schools are really working so hard now to teach it about it and to recruit more diversity in the classes. And I do think that understanding and addressing the health disparities is really becoming a major focus in medical education. And I suspect it will be. And I think that we will demand that it is until we reach real health equity.
Yeah, I also think that our current modes of healthcare education for providers, not only medical school, but it's in midwifery too, are not doing the best job in terms of really teaching care for Black and brown birthing people. And it is not only, in my opinion, as Dr. Karjane has said, it's not just the teaching and opening people's eyes to the implicit bias in the systemic and institutional racism. It's actually having equity in the providers that you have. That as a Black midwifery student, I think I was lucky, but I have friends who have had almost insurmountable obstacles put in their way as Black midwifery students. And it can be from the cost of going to school. It could be that you go to your clinical site and then you get a call that your clinical site doesn't want you anymore. So there are some obstacles for providers to be there. And part of what we have said earlier already tonight, that part of making this better for us is to have more of us there. There needs to be more of us as the providers, whether it be as OBs, MFMs, midwives, doulas, nurses. Like currently, the Black midwives make up about 2% of the midwifery population in America. And I would say that the number for Black labor and delivery nurses is about the same. So if you were to have more people who can relate to you, who have the knowledge, maybe that could be something. I think it would be something that would be helpful. And, you know, I can only do but so much on my own, you know, and I try every day. But if I had more and could help and bring other, you know, Black midwives up into this, bring other Black OBs up into this could actually help us to like break through and break these and turn these statistics around.
I definitely agree with that. I helped to introduce the Infant Mortality Review Board to the state of Virginia. So being that all of y'all are local, I'm gonna need y'all to join the review board team. They are so even prior to getting the bill passed to have a study on it, they were only focused about the funds, the money, and not that the Black women's infants are 9 times likely to die. Like we had child review boards and stuff like that, but they only studied the topics. So like suicide was the topic of last year. I'm like, what infants create suicide? Like, why is that even a thing? And so that was the biggest thing. And it's like maybe two Black women that are actually on the call, 2 or 3. And so we're all looking at each other like, so we can't think about anything else to talk about other than, well, this is going to be hard with the funding, and we need to make sure the General Assembly understands that we're going to need more funding. And I was like, can we talk about resolutions and like what we're going to do and like how are we going to form the board instead of talking about the funding of it? And these are all like medical professionals and all talking. And in my mind, I'm like, and y'all the people that's taking care of them. Okay. And, you know, I just sit back and take notes and just be like, this is the person who on the review board, and let alone because I am the executive director of Birth in Color, and what I actually stand for and what I promote, I'm always going to promote making sure that people of color are well taken care of. They actually didn't want me on the study. And so I was like, huh? They was like, oh, well, you aren't vetted yet. What do you mean? And so like I had to go above and beyond to people that I already knew to say like, you know, they told me no, I couldn't be on the review board. And why are they meeting prior to the bill being signed? Like, that's crazy. And so if I hadn't I said, well, what do normal people do? Because I had the connections that I had to say, hey, this is what happened, and they were given an ultimatum. What would someone who wanted to be on the review board who didn't have the connections do? Because if I didn't have the connections, they would have been like, oh, well, too bad. But listening to the conversation of these all medical providers, that all you're worried about is making sure that you're paid to do this work. When a person like me is like, well, regardless of the matter, I care about what's happening. And in order for us to create programs and to see what's happening, we need to know why the rate is so high so that we can create better programs, because clearly the ones that we have is not working. And so that makes me go back to the question of, what are you being taught when you go to medical school and then when you start your jobs and when you start your interns? Because my interns, like, I have a diverse group of interns, and I do that on purpose. And so one of my biggest things is teaching them how to be social, how to actually talk to each other, build their networks, build their connections, because we know in the United States it's all about your network. I teach them how to make sure that they can stand firm and that they can speak for themselves and never let anyone speak for them, no matter what position they're in, no matter if it's a job that you want really, really bad and you just don't want to speak up, to always speak up. If you're in a situation where you actually become an OB and you see someone doing something, to speak up about it. Whether you just pull them to the side and say, hey, I noticed that you did this. This is not okay. And making sure that they realize that it's not okay, because that's what's happening in hospitals too, where you have providers that are doing things and they know that they're doing them incorrectly, their counterpart, and no one is saying anything. And so I always reflect back to, well, what is medical school like? And as a person who is a student midwife, I've seen so much stuff that I was like, well, I didn't think I want to be a midwife no more, because if y'all have to be my preceptors, I don't want it, because I'm not going to be your slave. That's what we're not going to do. So being that, or like they was like, oh, well, you can't precept here because such and such. And I'm like, well, I don't want to precept there anyway. If you're going to treat them, do you treat all of them like that? And so like we are forced to create groups to support each other, because you're going through traumatic experiences, because you're going to school to be an OB or a midwife. Like those are things that the world doesn't see, that we as Black women and people of color have to create safe spaces to talk about the traumatic experiences that happen when you're going to school. Yeah. And it's like, when you tell people about it, they're like, you really experienced that? Yes, we actually do. And this is why we talk about what can we actually do about the schools for people of color and Black women. Because if you have a preceptor, if it's one that you don't know and you don't know the relationship, you're always treated some type of weird way. And like I've had several preceptors and it's always been like yeah, I'm not. And so like really my midwifery is like on hold. And I have all the Black midwives who's like messaging me like, well, wait a minute, what happened? Okay, well, we're going to put you here. Like, we still want you to finish and we're going to do this. And they have to talk to me about my traumatic experiences that I've already experienced. And so that's the reality of our world.
Well, I will say that when I was starting my residency, there was only two of us, I think three of us, that were female. And by the time I finished my residency, there was only one male in the entire program. And one of the reasons that OBGYN in general was an attractive field for me is that I felt like there weren't enough women in the field, to speak for and represent the patients, who were being seen. And I think that while there are some patients that do say, tell me what to do, doctor, and they really tell you they don't want to know the details, so they're looking for the old-fashioned paternalistic type of care, there's more and more people as the generations go by that really like complete information and so on and so forth. But I do think that, having representation from a diverse group of providers is key. I was reading in my research that only 5% of the medical providers are Black female, and 14% of our population is Black female, and only 2% of the OBGYN professors are Black females. And so, we definitely have an issue there. I remember even when I was in medical school from 86 to 90, we definitely had an affirmative action program where a lot of the minority students were given like a 2-week pre-medical school, and they had access to resources that the rest of the class didn't. And they really tried hard to get everybody to graduate with those extra resources. Not that everybody did, and there was still, a relative minority, but 2 of my 4 group at my anatomy cadaver were in that group. And one continued and actually works in our area as a family doctor, and one didn't. But, clearly there's things like Feeta was saying that predate you trying to make the grade in medical school. It has to do with your finances and, your family background and the various chronic stressors that you may experience. But having the ability to get people together and whether you're doing bias training or just creating more opportunities for fellowship and learning one-on-one how to, live in each other's culture and appreciate each other's music and, each other's food, and just have more personal relationships with people who have different backgrounds from you, is invaluable. I think in our area, we have a ton of people that come from India and Pakistan. And, I find that I'm lacking in understanding of their special needs sometimes too. And I really need help from them to educate me on how to better take care of them and draw them out and gain their trust, especially if there's language barriers as well. So it can come from a lot of different directions. But, since it's been over 30 years since I went to medical school, I would hope that, the numbers would have gotten better. I don't know exactly what they were then compared to what they are now, but I do think that, there are opportunities for, affirmative action or whatever you want to call it, and promotion of people in leadership positions to, help make it easier to identify and climb the ladder in academic medicine, where you have a greater impact, than you might otherwise have on students that look like you.
And I do think like the culture of medical training though, I just think even as a woman can be traumatic, like the things that you were talking about. Almost every woman who has gone through medical school, whether you're a woman of color or a white woman, like there are things that shouldn't happen, and a lot of times it's like quiet. I mean, I think they're being addressed, like there's clear sexism, but unlike years ago, like now over 50% of medical students are women. And you're right, like the number of women of color actually hasn't increased, significantly in the past several years, which is unfortunate. But I think as we have more women in medicine, the culture has definitely changed to being more like, I feel like kind and more nurturing, and not that, like that Socratic or the method where everyone is just sort of mean and asks questions and makes you feel dumb and belittles you. Like that is out the door now. And so, but I think that we need to listen to learners who feel traumatized by some of those methods and improve, because that's not the best way, I think, to learn. I think the best way to learn is to be in a nurturing environment where you're sort of propelled forward, as opposed to in an environment where people try to kind of knock you down to make you stronger, because that's just not, I mean, that's not the way I function. And I think it's not the way that most people are going to be successful. And I do think medicine is changing though, and needs to continue to move in that direction.
Ms. Sutton, I want to just thank you and Birth in Color for doing this program and highlighting the disparities here, and it's obvious. And to answer that question, no, I don't think we're doing enough, or there's not a good job being done in most institutions of training health professionals across the board, whether it's midwifery or medicine, okay? I agree with Nicole. I think there are initiatives that are being put in place to change that mentality. So with last year and the Black Lives Matter and the anti-racist protests, it wasn't just only about police brutality. It shed light on the disparities of all walks of life, from financial to healthcare disparities, housing disparities. So it really was an eye-opener for a lot of things going on in our society. So some of the things I had mentioned before, that the American College of OBGYN is trying to have a cultural change and really having us to really reflect about what our implicit biases are in our cultural and institutionalized racism is, and try to change that. And so some of the things I think that could be done, and some schools are doing it, where they're trying to combat that racism and break down those barriers of biases and all of that, but to also teach some community engagement. So I think Ashley was the one who mentioned it before, that we're all doing different things with the same goal in place. That is to take care of that woman and having the best outcome for her child and her birth, right? But we're all going at different channels. So somehow we all need to come together, you know? So if, you know, Birth in Color, Dr. Brown, Nicole, Feeta, you know, if somehow we could all merge and be that advocate for the patient, teach these residents in medical school advocacy skills and community outreach, you know, programs that you can go out there to different communities, and not only just talking about Black women. Think about Hispanic women and the language barrier. Go to, you know, get people who speak their language and go into their communities. That's one way. You talk to also Ms. Sutton about the trauma of being a Black woman going through your midwifery program. Well, I too experienced that going through medical school, but there was not a space for me to sit and talk with anybody. There was no place for me to debrief or really get help, you know. We as mental, you know, medical providers need mental health space too, and help, right? So, you know, if there's a space that can be created in these institutions where you can debrief and collaborate and feel safe to do so, I think that would be awesome. And then thirdly, you know, I think Dr. Ivy-Crowe said that, access to care, going out to those communities, whether it be mobile vans, taking those residents with you maybe once a month, taking them to maybe healthcare centers, places that are in the communities. You know, I was thinking about it the other day with the COVID vaccine. It's not rocket science. Not everybody has Wi-Fi. You don't even have to think about the inner city. You can think about rural America, Appalachia in West Virginia. They don't have Wi-Fi there in some places. So how in the heck are you going to ask them to go online and register with the state to get their vaccine? Take the van out there, take those vaccines to them and give them the shots if they want it. You know, you can take your medical students, you can take your midwives, you can take your nurse practitioners, whoever wants to volunteer. But that's why I'm saying we all need to try to just come together and see what we can do. But those are things I think we can do to improve and really, really, really train our next level of health professionals. But I think we're not doing enough.
I appreciate that, Dr. Greaves. In Virginia, we have royal communities like the Northern Neck, Northumberland County, Lancaster County, all of those areas where I grew up who still don't have internet. I mean, I only go to my mom's house and I'm like, 2 hours, I'm ready to go because you don't have internet. And she's always like, well, I have my little box. And so she'll hook up her little Wi-Fi boxes from Verizon. That's like $100. It's like $100 and she only gets like 2 gigabytes of internet Wi-Fi. And I'm like, Mom, for what I need, I'm gonna have to run you all day long. And so that's another area that they're talking about, but what is actually happening, what's being done about those areas. They don't even have a maternal ward in that area. They drive 2 hours to give birth. And so that's problematic. And so that area is actually one of the highest in not receiving prenatal care just because of the lack of access. And so when you look at those numbers, it's like, but who's actually working on projects to actually create something, a resolution for them? So that brings to the next question. Well, I think we already answered that because Dr. Greaves gave some great advice on what needs to be done for the poor quality of care that women of color actually receive in the healthcare settings. But I'm gonna ask y'all this question anyway so everyone can answer. What do you believe must be done to end the poor quality of care that women of color face in healthcare?
I think I had, as I had said earlier, but it's addressing and dismantling implicit and implicit bias, institutional and systemic racism, and helping people to recognize their privilege and bias when they are working with and caring for women, folks of color, and also dismantling and breaking down the roadblocks that people of color face to be the providers in those spaces, to be an OB, to be a midwife, to be a nurse, to be a doula, like breaking down those blocks so that more people of color can be in this space. And then also breaking down and dismantling the racism that undergirds the bias that reinforces the poor quality of care that women of color get.
Well, I think everybody has given us tidbits of all the different things. If we could collectively put all those things together and get them done, everybody throughout, for every question that we've gone through, people have come up with suggestions. And it's just like you said, it's a matter of just not saying it. What do we need to do to execute it, to make it happen? And to make it happen, not just in our neighborhoods and our backyards, but all over the place, because they are all valid things and things that we didn't have to look at when we experienced them. Just like Dr. Greaves said, stuff started in medical school, but you never had you had nobody to talk to because you didn't have anybody to look like you. And then you didn't always know what to do with what you were getting back. And, having not been raised in that environment, when you got those things happening to you, you had to kind of say, is that really what they said to me? It's so many on so many different levels, starting with breaking barriers, starting with what we teach our kids, starting about trying to get rid of all the what we've been raised, our perception of what's not believing the medical profession, not trusting, not, people not taking time. But it's just, if it would be nice, you did a recording, but to sit down and itemize all those things that everybody has said, and then put it on a piece of paper to say, this is this, because then it becomes real. And then it gives us a platform of where to go next. The next step we've identified. Now, how do we impact? Who do we need to talk to in any area? Medical school, culture, somebody put on their cultural competency. We never got any of that. We got it by living it, by just experiencing it around the people. But it's a start just to collect all the different beautiful ideas that everybody has collectively put together tonight to say, this is where we need to start. And just take that information and use it as a platform for just everybody. If we, it's a foundation to start with. But I think we all have come up with some great ideas and references and put it down on paper to say, now let's see what we can do with this from what small area of influence that we even have.
I have some experience in our hospital in Loudoun. We have a birth navigator and sort of like a breast cancer navigator. And both of those things are not, specific to race, but they certainly can come in extremely handy.
I'm on mute.
When you have a challenging patient situation. And so I think that is a big step in the right direction if you have resources like that in your facility to help out. And they're happy to help out, long before the patient is admitted to the hospital too. Then I think that the postpartum VA organization in the state of Virginia has been very, very helpful to get patients in a better place to deal with postpartum depression, which is higher in our Black patient population due to a lot of their stressors that they undergo. But I mean, even doing little things like making sure the images on your wall aren't just all of white babies or even young women. I mean, sometimes putting older patients on the wall that don't necessarily have a baby in their arms, can be very useful. I think Dr. Ivy-Crowe was talking about having a document. If you read that ACOG joint statement that came out between them and like 18 other women's organizations, they have a lot of concrete plans, as does the HHS plans. But, I do think a lot of it does come down to funding at a state by state level to make sure that you can have the personnel to help out with those roles. I know that when I was a resident in inner city Pittsburgh, I can't tell you how different the patients were from me, in terms of their upbringing and their culture and their, financial situation. I mean, if I could count on one hand the percentage of patients that I delivered who were married, for instance, when I was a resident compared to the vast majority of them now in private practice, it's the opposite kind of ratio. And I could have really used a primer, when I went and sat down and tried to be some sort of expert taking care of these patients for 4 years in our clinic. I think it was they just threw you in and expected you to know what you were doing. I really embarrassed myself. I'll never forget this. A woman came in and she had her child, her toddler, with her, and the toddler had long hair. And I, assumed that this toddler was female. And so I was complimenting the woman on her beautiful little girl, and she had to tell me, no, this is a little boy, and in our culture, we don't cut their hair for the first year or 2 years or something like that. And I was just so embarrassed, but nobody ever told me that before. I never knew that, and she was pretty annoyed with me at the time. So I do think, depending on where you live and what your patient population is, the patients deserve their providers to be prepared on how to deal with them differently, if they come from a vastly different socioeconomic and cultural background.
I think even kind of piggybacking off what Dr. Brown is saying, I think that even speaks more to being in the community, like bringing residents, med students, and, if you are someone that is from outside the community, moving somewhere else to do your work, being in the community so that you can ingratiate yourself to the community, learn what is, the mores and the, common things that happen in that community, so that you can better serve them. And I think another thing too that can help to help improve the care that Black women and people of color get, and not only Black women and people of color, but all birthing people, is, removing the roadblocks to make it safe for birth, not only in hospitals, but in birth centers and at home. You can have safe birth at home with a qualified provider. You can have safe birth in a birth center, where I am now. You can have safe birth in places outside of the hospital, and making it so that, like, legislation in all the states, working on it here in New York, but legislation in all the states to make it so that you can have safe birth in all the places where you can have safe birth. It doesn't only have to be in the hospital. Sometimes part of what may cause somebody stress is being in the hospital. But if they had someone who could get the schooling and get the licensure and be able to safely practice in their home so that they can have their baby surrounded by their family, that could be the best outcome for them, compared to those who do need the increased care amount of the team that you need in a hospital setting, and they can do it safely there.
I definitely agree with all of those options, and I love every last one of them. And so what happens after this panel, Dr. Crowe, is that all of the ideas that have been mentioned here actually will be written down, and you guys will receive a copy of them as well. just to make sure that you guys can, follow them and wherever you are, you can implement different things and different ideas and different approaches to the communities that you serve. Because I do realize that we're all across Virginia. However, we can always unite in creating different projects and different awarenesses and different initiatives across Virginia as well. Question. According to the CDC, 68% of pregnancy-related deaths are preventable, yet they are highly prevalent, especially among women of color. How does this statistic make you feel, which I think we've all talked about how we felt today? What can be done to stop this? But I would like to put a spin on this question, because we've already talked about the statistics. We've already talked about what can be done. So let's talk about what's actually happening beneath the surface that a lot of people don't like to necessarily talk about it. And so every panel discussion, I'm always going to be the one to say it because some people are uncomfortable with saying it. However, Dr. Greaves already said it. But racism is one of the underlying issues that happen every single day when clients are going to their providers. I remember when growing up, I grew up in Northumberland County, super racist area, but all the children got along. I remember a friend of mine, we were really, really close. She was white. She said, my mom says that I can't play with y'all, that I'm not supposed to like Black people. She says, but I don't care because we get along and like, you're my best friend. So I was like, well, we don't have to worry about what your mom says. Like, we're taught to like all people because we are. And so when that happened, her mom would, oh, I see you talking to them, or we would have to hide like in school because we was on cheerleading squad and all that type of stuff together going all the way up through high school. So how it blew back in her mom's face was that once she got to a teenager, she didn't care. She was like, well, I like them. I like their culture. I like everything about them. And so her mom would actually see us together. Every last one of her mom's children, she had all daughters. Every last one of them is married to a Black man and have children with a Black man. So she was forced to like everybody. And so I actually saw them a couple of years ago, and her mom actually spoke to me and greeted me for the first time in a very nice way. And I was like, and look at that. And in my mind, that's what I spoke back, of course, because of the person I am. But in my mind, I was like, and just look how that happens. But I want to hear about like if you've actually noticed this in your practices, and what are you actually doing about it when you see it?
I don't see a lot of explicit racism in my practice. We have a fairly diverse staff, and we all try to be sensitive to each other and so on and so forth. I think that, I probably have, more challenges with some of the other races that I take care of, just because the cultural divide is a little greater, and communication is a little bit more difficult. But I definitely think that there are a lot of national efforts. You may have heard of the CMQCC and the AIM, and these are organizations that the ANOVA system in Northern Virginia is working with very closely to address specific areas that I think are the main causes of maternal mortality, particularly hypertensive disorders is a big thrust right now, and also, hemorrhage, and the maternal early warning system, the MUSE, has been designed to help nurses pick up more quickly on patients' complaints and escalate them more rapidly. And I think that that is going to be, most impactful on women of color, because I think that they're more likely to have a lot of these, complications, especially in the hypertensive realm. And so I have found that our efforts in quality have focused a lot on working through algorithms and order sets so that things don't fall through the cracks as easily, and I think that that's a more sort of colorblind approach to things.
I work within an HMO system, and it's quite diverse. And I think within our department, it's quite unique. There are quite a lot of women of color, surprisingly. So it does make it a difference, I feel. But what I find is more so when the women go to the hospital, where there might be a little bit more of the issue. So like Dr. Brown said, what we're really doing at on the hospital level is there more approaches at more standardized algorithms and workflows, so that way everybody's treated the same and you will be able to recognize when there's a problem. So an example is in women of color, particularly Black women, we suffer from a lot of hypertensive diseases in pregnancy, meaning your preeclampsia and so forth. So once that woman comes in, you see a blood pressure of 150/100. That nurse needs to be taking her blood pressure ever so often, need to notify the doctor, get right on it about getting her lab work stuff. So it's like clockwork, okay? And you're not waiting for her to seize, and then you're running, by that time you're behind the 8 ball. And so in terms of preventable deaths, those are some of the top things. Women of color die from hypertensive disease of pregnancy, postpartum hemorrhage, okay? So, and then thromboembolic syndromes like your pulmonary embolus that I mentioned about Serena Williams. So those are the top 3 things. There are so many other things, but there should be that red flag. I'll give an example of a young, for people who do Facebook, I was part of a Black physician group, and they mentioned a young intern in pediatrics who was pregnant, and she was having right upper quadrant pain. And they weren't really paying attention to her, oh, you'll be fine. It's, but come to find out, she had full-blown severe form of preeclampsia, and she ended up dying. And she was a medical doctor, and a resident. So this was just tragic. So one thing that we do at our healthcare system, we do have this thing called the perinatal service group, where we have a nurse who, if right away you're diagnosed with hypertension in pregnancy, you're put into this group where the nurse calls you weekly. You're given a blood pressure cuff where they're checking your blood pressures daily, and it's automatically being fed into the system. So we get an alert. So one day I was on call at night, and I'm like, why am I getting an alert 2 o'clock in the morning from the perinatal nurse? This woman's blood pressure was 160/100. Immediately they called her. They had her come into the hospital right away, and we did serial blood pressures, and she was preeclamptic, and we had to deliver her prematurely. But those are the kind of things, if you have standardized protocols and algorithms in place, then nobody gets missed. Because the problem, what happens in these 60% or higher preventable deaths, is that misdiagnosis or delayed diagnosis and treatment that, again, maybe people are not paying attention to what the person is saying, or not picking up on these cues that this is what is happening with that person.
Yeah, I agree. I definitely think it is standardizing care in your practice so that you are recognizing the signs if they present themselves, but also definitely educating patients about what those signs are. I've made it a routine for me every time I see a patient, especially when they're in the second half of the pregnancy. These are the signs of preeclampsia. You have our number. call us immediately if you experience any of these. If you have any concerns, if anything feels off, call us immediately. And also realizing as your team, you having your team know that if people are coming to, if you have a patient who comes to you with these concerns, to take it seriously. And so it's that two-prong approach. It is us as the providers having our standards to approach these things, and then letting our patients know, we're going to empower you and be open to you. Come to us, whatever you're worried about, even if it's the smallest thing, let us know, because that small thing could be the big thing that we can do to save your life.
And then it's that patient, physician partnership. And then that's where doulas and other mid-level providers, especially in the delivery room, if we have doulas, that's where you can play a critical role, because you're also being the advocate for the patient. And then one thing I want to mention, sometimes with the doulas present, sometimes they try to make it adversarial, which is not what we're trying to do, right? Because we're all a team. So you want to work with the doctors, but of course, if you don't make it antagonistic, so it's an unpleasant situation for the patient, right? But of course, if you pick up that there is something going on and you see the nurse is not, picking that up too, and the doctor's not necessarily in the room, you want to bring that to their attention. So that way we're all providing the best care necessary for that woman.
Yeah, I definitely agree. And that's what I tell all the doulas when I'm training, is that you're there for the client, but to make sure that the client is getting the best care, you are to work with the provider in helping to ensure that it's a peaceful environment. And there's ways about that. You introduce yourself, and knowing your scope, especially because doulas are even though they've been around for years, they're more trendy now. And so you have all of these people that are training doulas, and it's when you look at the curriculum, you're like, why are you telling them to do that? Because that's technically out of their scope. So making sure that even you're there to help them advocate for themselves, but that you're still allowing the client to be in control of their birth. That's very essential, is that it is the client's birth, and you can provide them evidence-based information, but you are not to make the birth hostile or be aggressive to the providers, because essentially that is between the provider and the client. And knowing not to overstep those bounds is really, really important when it comes to doulas. So I always make sure that I provide that education to them, and allowing them to know what the scope really is. And that's why I show them how to partner with community health workers. Like if she does have a preeclampsia issue or something like that, showing them okay, this is where you would build a resource. They can go into the homes and do blood pressure cuffs. That is out of the doula scope to do a blood pressure. Because you can do the blood pressure all day long, but if you don't know what to do after, it's null and void. And so here in Virginia, in Hampton Roads, Centera, Megan Bolstowitz, she did a partnership with CHIMP. And so the postpartum preeclampsia is an issue that's arising. And so if they have high blood pressures upon leaving, they actually are giving them blood pressure cuffs. And they have a nurse that will come through every other day to take the blood pressure. And just to do a follow-up call and check in and say, hey, how's it going? Did you check your blood pressure? Did you do this? Did you do that? Because we need to make sure that they're cared for postnatally as well. And that's key. But I definitely want to thank you all for participating in the discussion. Truly glad to network with you all and to hear all the great advice from everyone who actually does this work, who creates change, who wants to see the change, who definitely talked about solutions rather than just having conversations. Because we've been having the conversations for years. It's been an issue for years. So implementing those solutions is going to be key to bringing those rates down. And I want to thank you all for all of the great work that you all do in your areas. You can always connect with me, refer clients. If you just need some type of advice, help, or anything like that, you can always reach out to me, birthingcolorrva.org or Birth in Color RVA Foundation at gmail.com. That's my actual personal email. So you can always email me with any type of questions, no matter what it is. No question is stupid. I have to make sure I always say that because people will be like, well, I thought that was, no, by all means, my door is always open. It's always a safe space. So I will never share anything personal that you actually send to me or ask me, or if you want to have a quick phone conversation, I'm always up for that too. And y'all can all look each other up. I'm not going to share anybody's personal information because I don't want anybody to get mad. But every last person is on Google. So you can always find that information if you Google it.
Thanks so much for doing this.
Yeah.
Yes, thank you.
Yeah, it's been great. Thank you so much.
Thank
awesome.
you.
Thank you.
I'll give a shout out to my interns who made sure this happened. They are all listening. I see their names.
I see Brianna.
They're definitely
Yes,
brilliant.
Brianna.
They helped create this, and the questions all came from them. So kudos.
You still gonna be an OBGYN?
I was going to just ask that. Because you have a lot of resources here, I think, on this call to be able to help you get to, if that's what you want. You don't have to.
The field of women's health is something I'm very passionate about. And I really appreciated hearing all of you speak as a guest here tonight. Because just from my classes and what I've learned in school, what I've learned from my own research, by 2050, we're looking at a world where the minority will be the majority. And so it will be very interesting to see how healthcare changes and acclimates to the new majority in the country. And honestly, we should start now with the change. We shouldn't wait till years to come and then we're all stuck looking at each other like, what are we supposed to do with all these people who we let fall by the wayside years ago? And I think it will be very interesting to see how public health and just healthcare in general changes. I currently work at the health department as the lead of logistics for COVID-19 for the Credit Health District in Petersburg, Virginia. And last week was Public Health Week, as I'm sure you all know. And so last week I spent my week going around to mobile home clinics, mobile home communities and different senior homes and homeless shelters, passing out the forms to give. And like Dr. Greaves said, it's all about going out of your school, getting out of the office, getting your hands dirty, and really being there for the community that you say you serve. And so it's going to be really interesting how we change to make those people feel welcomed in healthcare, because at the end of the day, everyone matters. And so I appreciate you all and your strides you're doing in your community to make that change. And it's an uphill battle, but I do believe we can get there. Like Dr. Greaves said, it's embedded in racism, and that's something that is going to take a long time to change. But little by little, we can all change the fields that we're in.
Amen.
Amen.
Mhm.
Thank you.
Thank you. Thank you for having us.
You guys have a good night.
Well, good evening.
Have a good night, guys.
Thank you.
Thank you. So nice to meet you all.
Likewise, everybody.
Bye-bye.
Bye-bye.